So thank you for the invitation to talk um, at this Lymphoma Hub. And I've been asked to answer the question, when is the second CAR T-cell infusion feasible for patients who fail prior CAR T-cell therapy? So my name is Jordan Gauthier. I'm an assistant professor at the Fred Hutchinson Cancer Research Center in the University of Washington in Seattle. So this question is at this stage, we don't really know what the best approach is in patients who do not respond or who relapse after CD19 CAR T-cell therapy. And one possible approach would be to give them a second or repeat infusion of CAR T-cells. So as a first disclosure, at this stage, this approach is not uh, doable outside of a clinical trial, so not possible to do this with FDA-approved or EMA-approved commercial products, although it might become possible in the future. So the first step to be able to do this would be to manufacture a new CAR T-cell product. And there's different ways one can go about it. In our experience, in a majority of patients using our in-house manufacturing, we could use leftover cryopreserved cells that were collected at the time of before the first CAR T-cell infusion. So they can be at different stages of the manufacturing process. The second option would be to have your patient undergo a repeat leukapheresis. In our experience, we only had to do that in 2 patients. And what we found in our data in 44 patients who received the second CAR T-cell infusion with for a B-cell refractory B-cell malignancy, we found that this approach was more efficacious in patients who had received cyclophosphamide and fludarabine-based lymphodepletion prior to the first infusion. And this is the case at the moment for virtually all CAR T-cell patients because this is the recommended lymphodepletion regimen for both Yescarta or Kymriah. But even more importantly, we found that best results could be achieved by giving a higher dose of CAR T-cell at the second for the second infusion, 10 times higher than the first infusion. And we found that in CLL and NHL patients who did receive Cy/Flu prior to CAR-1 and a higher CAR T-cell dose at the time of the second infusion, the overall response rate was 70%, and response was durable in a subset of patients, and overall the median progression-free survival was 6 months. So in summary, for this approach to be feasible, you need to be able to manufacture a new CAR T-cell product, and we found that this approach led to superior outcome in CLL and NHL patients who had been exposed to Cy/Flu lymphodepletion prior to the first infusion of CAR T cells, and even more importantly, who received a higher dose, 10 times higher at the times of the second infusion.